All right, I'm Jesse Selwyn. I'm an RT here at St. Mary's, and since we ceased the ventilator rounding, we decided to try something new to give you guys some better education with the ventilator. What that's going to entail is basically some case studies. We've got two today, highlighted by Dr. Dreitlein and Dr. Paddock. In the future, we'd like to get you, the crew, to highlight various event cases that have been difficult for you. So we will jump right in. They're going to be fairly distilled. If the vitals are good, I won't really mention that too much. If something's out of whack, we'll let you know. And again, it's focus, ventilator management, and the best way to handle these patients that you're seeing in the real world. So case number one, these are all outer facility transfers, say that, and we're not here to roast anybody or single anybody out. This is purely a learning experience for all involved. So, case number one, 74-year-old male, ideal body weight 75 kilograms, which gives us a tidal volume range of about 375 to 600. That is 5 to 8 milliliters per kilogram. He has history 1 week worsening shortness of breath with upper respiratory infection, productive cough, low-grade fevers, flu negative, strep positive, increasing O2 demands. The crew gets dispatched to transport this person to St. Mary's. Upon arrival, he's working hard, bilateral rhonchi that they can hear across the room, pretty consistent non-productive cough, increased work of breathing. The crew, the attending physician, the patient all agree that intubating is maybe the best course of action for the transport. And previous history includes AFib, PVD. There is an x-ray from that facility that shows right upper lobe pneumonia and a small right-sided effusion. So they RSI him. It's an 8O tube. There are thick secretions in the airway upon intubation. They get it first try. Verified end tidal, chest x-ray, all that stuff is good. They place him on the vent. CMV plus, tidal volume of 550, which is in the neighborhood of 7 mils per kilogram body weight. Rate of 15, 100%, and 7 of PEEP. End tidal at this point is 47, so maybe a little elevated. All of the other vital signs are doing okay at this point. His peak pressure starts alarming. The alarm is set to 40. It should be noted that on this ventilator, your peak pressure alarm begins at 10 below. So if you want your true pressure limit to be at 35, which means the vent will cut off its flow at that mark, you need to increase that alarm to 45. So your peak pressure is at 35, and it's not delivering the volume that's set. So we're trying to get 550, it's only delivering 400 to 450. So the crew at this point raises that alarm up to 45, which is a point of contention. So that gives your peak pressure at 35, which is still okay, but I just want to make sure that people know raising your alarm to achieve your set tidal volume is not the way to do it. That would be, on nursing side, the equivalent of saying, my blood pressure is 200 over 100. I'm going to raise my alarm value instead of looking for what's actually causing this or trying to treat the cause of this. So, increasing the alarms to increase your pressure, if it's set appropriately, is not the way to go about things, which the crew seems to understand. They did drop his pressure to 450 cc's, which is then a 6 mil tidal volume.
Yeah, his tidal volume they decreased.
They decreased
Yeah, okay.
from 550 to 450. So now we're at 6 mils per kilo, trying to do some lung protective. They're still getting peak pressure alarms. So at this point they switch to pressure control ventilation. On the Hamilton, you enter in your inspiratory pressure over your PEEP, and those two combined give you your PEEP. So we're on 25 over 10, which peak inspiratory pressure is roughly 35. That's giving volumes of about 425 to 450 cc's. So we're kind of okay there. At this point, somewhere along the line, neb's given for increased work of breathing, increased wheeziness. They also increased the vent rate to 18. Our end tidal is 41. The patient is paralyzed and sedated. At some point along the line, with that sedation increase, the patient drops their pressures to 90/60. Fluid bolus is initiated. At this point, they also drop the FiO2 down to 90%. And increase our PEEP to 12, citing lung protective strategy. And at this point, your SATs are 94%, your CO2 is now 35. So we drop the FiO2 and increase your PEEP. You certainly could do that, but you're kind of holding your own, so it's questionable. Should I raise the PEEP to 12? Which puts increased pressure on the vasculature, dropping your pressure more. You want to tolerate 10 of PEEP and higher FiO2s for the duration of the flight. In my choice, I would say let's just leave it at 10 of PEEP, deal with the pressure, your SATs are maintaining, and go with that.
So, Jesse, where does it come into play your ARDSNet type protocols, where isn't it if your FiO2 is higher than 50%, you should still be working your PEEP up? Is that accurate?
Still work the PEEP up. That's accurate. They do have a whole timeline there. But when you're trying to balance blood pressures and things like that, particularly in the setting of being in the helicopter, what are we going to do here? How are we best going to stabilize this patient? Because the next set of vitals, the blood pressure's dropped even more following a fluid bolus.
So not trying to fix it all at once.
So you're not trying to fix it all at once. It's let's focus on, one thing. It's, their PEEPs are 10, you can go up. They're satting okay on 100%. But for the duration of this, let's just,
that 100% doesn't worry you too much during the length of a transport. It's a good goal to try and up PEEP some to lower that down from 100, but not be hoping to get really low with your FiO2 down to the 50s. And you can't fix all that in that amount of time.
Especially with dropping blood pressures. And obviously you can't have a patient too awake and alert, so you don't want to drop your sedation too much and then fight the vent or fight the crew. So this next drop in pressure, the crew does start some norepi, improves the pressure. Our SATs are about 93, our CO2 is 40. And at this point, they're basically at St. Mary's ER and transfer of care. So, as Barry was saying, it's certainly a difficult choice to make between increasing PEEP, drop FiO2, but for the duration of a flight, 40 minutes, 60 minutes, it's not going to do tremendous harm to have that 100% or 90%. Hovering in the low 90s is totally acceptable. The big one is just lung protective strategy. Your peak pressures are high. Switching to pressure control, I think that's great. The vent, here's the struggle. The vent, the Hamilton cannot do a plateau pressure. Plateau pressure is really where the damage is done in the lung. A peak pressure, 35 to 40 is kind of what your limit is. Plateau pressure of 30 is what you want to try to keep it under. And there are ways, in a later video we can show you some ways to get a plateau pressure. So that'll be coming along, but keep in mind, high pressures, more time spent at high pressures is certainly damaging. So if you have a peak pressure alarm, there's a couple of things that you can do. It's a useful acronym, DOPE, D-O-P-E. First one, D, is displacement. Is your ET tube in the correct spot? Same thing if the person has a chest tube. Make sure that chest tube's where it should be. If it's a tube, particularly ET tube, if it's rotated, is it pushed up against the carina, something like that. Check that. The O is for obstruction, secretions, it could be any other form of obstruction. P is your patient. This person all of a sudden, do they have a pneumo? Are they having a bronchospasm? Once again, back to the secretion. Are they bucking the ventilator? Do they need to be sedated a bit more or something like that? And E is equipment. That could be certainly a ventilator failure. Is your tube kinked? Is there a problem with your circuit? Those types of things. So that's a great acronym to kind of remember, DOPE, to just go through and diagnose this. Why am I getting pressure alarms?
And I've had always learned that as the P being pneumothorax. That was the example you used.
Yep.
That's a useful mnemonic for both ET tubes and chest tubes.
Yep. And so a few things that you can do with high peak pressures. If you're getting peak pressures, and in this case they intubated while they were on scene, and then transfer of care here. So it's not noted, but one thing you can do, it's always good to bag the patient and actually feel what their lungs are doing. Are they stiff to bag? That'll tell you a lot when you put them on the ventilator. If it's hard to bag, it's going to be hard for that ventilator to push that air in, and you're going to need to use a smaller tidal volume. Your flow volume loops, it's a little more advanced, and that's something else that we can talk about in the future. But with those, you can see airway obstruction. You can kind of tell if there's secretions in the airway. So it's a very useful thing. It wasn't noted in this chart, but this patient had secretions in the airway during the intubation, had a pneumonia on x-ray. It wasn't noted if there was any suction involved. That's certainly a big thing in creating peak pressure alarms. That is peak pressure involves airway resistance. So it's that air blowing through your ET tube. It is blowing through secretions. It is fighting the chest wall and the weight on that chest. So keeping that airway clear and those secretions managed can go a long way into improving your alarms and your patient compliance. Along with secretions and the need for suction, being in a helicopter, you certainly can't hear things very well. One thing, you can always put your hand on a patient's chest and feel with those inspiratory efforts on the ventilator, you can feel a lot of times things rattling in the chest. If it's particularly bad, you can see foam, you can see secretions in the airway itself with coughing. So those are indications, that suction may not be a bad idea. Case number 2. This is a 67-year-old female with a history of COPD and flu. She presented to the ER, once again out of facility, with severe upper quadrant pain, about a day worth of vomiting. She also has a very recent COPD diagnosis with HOMO2. Additional morbidities, she does have a mesenteric artery thrombus. Bibasilar pneumonia is on her chest film. She is admitted to that facility, declines, and is eventually intubated for respiratory failure, both hypoxic and hypercapnic. At this point, the flight crew is dispatched, and when they arrive, they find this patient's been intubated with a 7.0 ET tube, is on assist-controlled ventilation, a rate of 18, a volume of 400, 5 of PEEP, and 80%. This person's ideal body weight is 50 kilograms, so that 400 cc tidal volume is 8 cc's per kilogram. Remember, 5 to 8 cc's, cradle to grave, is our range. This patient is sedated, but is overbreathing at a rate of 28, and a peak inspiratory pressure of 30. Pertinent vital signs. Patient is rhonchi with wheezes bilaterally. She has a chest x-ray at the facility showing appropriate ET tube placement. Also showing, per the report, acute or chronic interstitial lung disease versus pulmonary edema with worsening right lower lobe opacities. So kind of the mixed bag there, but certainly a pretty interesting lung process going on there. Like I said, she was intubated at the facility. The physician there, I believe it was a CRNA, did have to give her some push dose pressors prior to the intubation, during, and after. The flight crew, prior to leaving, did start her on ketamine with some fentanyl, and also a levo drip just to maintain her pressure. They placed her on the Hamilton ventilator, so it's going to be the CMV plus, rate of 18, volume of 400, a PEEP of 5, and 100%. On those settings, her vitals, her SpO2 was 91, and her CO2 was 32. And it should be noted that she did have an ABG on that 18 and the rate of 18 and the volume of 400, and that was 7.42, so within normal range, pushing towards the alkalotic side. CO2 of 31, so a little bit on the low side. 84 was her PO2, and 20 on the bicarb. So that'll come into play here, so keep those numbers in mind. So we've got her on our ventilator. Peak inspiratory pressures are fine, 24. She's over-breathing it, 28. They do some suction. It's not noted whether they got anything out. But we're on this 5 of PEEP and 100%. So in flight, the patient's oxygenation drops down to 90%. End tidal's 25, so we're still trending down. At this point, it's noted in her chart that the PEEP is increased to 10 for SpO2 sats. COPD reported concern for possible obstructive process. With this increase in PEEP, shortly after it's noted that her O2 continues to decline to 87%. Her CO2 is 30. The PEEP is then dropped to 5, and it's noted air trapping concern. And she basically sticks at 88 to 91% SpO2 for the duration of the flight. The end tidals stay 25 to 30. So here's where we want to kind of get into the discussion on this one. So Dr. Paddock in his vent talks has kind of mentioned that you have two forks. You've got your obstructive process fork and a lung protective strategy fork. Obstructive processes, COPD, asthma, things like that. The protective strategy, almost anything else. Illness, someone with healthy lungs that is a trauma patient, those sorts of things. In this case, it kind of appears that they went down the obstructive process fork as opposed to the acute illness fork, and there's concern of air trapping and just the general obstructive thing. So air trapping in real life rarely causes issues. Certainly your status asthmaticus patient or significant asthma, that's one where air trapping is a true and valid concern. The COPD patients, that is typically very end-stage COPD patients that have that. This one was fairly recently diagnosed. Some HOMO2, but the presentation doesn't sound like it is significant. This isn't the person that has a huge barrel chest. This isn't the person that's very, very close to end of life with very small tidal volumes as it is. This is a person that has a diagnosed pneumonia. We can see it on the chest x-ray. We can see it clinically. Bronchi, wheezes, that sort of thing. So the oxygenation issue, that's our big problem there. That's what's going to cause our damage. The body can tolerate acidosis decently well, but it doesn't tolerate hypoxia nearly as well. So continuing to that obstructive process, IE to ratio is the big one there. You want to give that person time to exhale. This person had end tidals in the low 30s with good ABG correlation. They were on a rate of 18, over-breathing. Some of this could be, as the patient fighting it, which it kind of sounds like they were, according to the charting. Say the patient's fighting and they're giving ketamine and fentanyl to try and counteract that. But you have room to kind of decrease that person's rate if you need to. The peak inspiratory pressure was 24, totally fine. So the 8 ml per kilogram tidal volume is very acceptable for this person. The PEEP issue, PEEP of 5, 100%, low SATs, so it was increased to 10. SATs then kind of dropped off a little bit. You did some suction, so that's all great. They then dropped it back down to 5, worried about some air trapping. And here's another big thing. It's been stated that particularly in CRIT, that on air trapping patients, obstructive patients, to use 0 PEEP, ZEEP, or start at low PEEPs. Talking to most of our physicians here at St. Mary's, our intensivists, we don't want to do that. Basically start at 5 of PEEP, and then increase from there as you need to. There's not really any evidence base for ZEEP, and with ZEEP, or 0 PEEP, you can actually increase that person's work of breathing. If they are air trapping on their own, basically they're unable to get more big tidal volumes, they're so full they can't generate inspiratory flow to overcome that PEEP, they can't trigger the ventilator. By increasing your PEEP, you basically decrease the amount of work they have to do to trigger that ventilator. So it can improve your patient compliance, patient comfort, decrease work of breathing, all good things. A patient who is fighting the ventilator, a patient who's more awake, arousable, moving, all those things increase heart rate, they increase your metabolic demands, your CO2 is going to increase, their oxygen demands are going to increase. So whatever we can do with that ventilator to make that person more comfortable is a good thing. Managing the sedation along with that is also beneficial. So in this case, the obstructive pathway was not really an issue. There's a few things they could have adjusted if that had been concerned. But this oxygenation, increasing your PEEP, that's the good move. You saw a slight decrease in SATs afterwards. Making sure the SAT probes are correct, making sure your pressures are there, good thing. And sometimes, a lot of times, the body takes time to adjust. If we make changes in PEEP, it can take time to see that change improve. Initially maybe your pressure drops, but after 5 or 10 minutes, that person then responds, and now SATs improve, pressure stabilizes. All those things are good. If there's fluid in the lung, it takes time to push that fluid out. So write it out if at all possible, and don't spend too much time worrying about this intrinsic PEEP, this air trapping, unless it's an asthmatic patient or someone with advanced lung disease.
Excellent. So for a couple of review points on that is just kind of clarify what's the most likely path, obstructive or lung protective, that is going to apply to that patient.
In this case,
go to that path. And in this case, it looked like the paths were blended a little bit.
They were.
And most likely, except in extreme cases, COPD is not likely to be a huge air trapping problem. And with the X-ray and the secretions and things, you could anticipate more of a pneumonia, more of a lung protective strategy would have been more clear to go straight down.
Yep.
One point about this chart mentions that they were overbreathing the vent, and I just wanted to talk about overbreathing the vent a little bit with you, because one thing I will see crew members do is say they're overbreathing the vent, they need more sedation or something, and my training is really that overbreathing the vent, they're meeting their needs, they have their own drive, those are all good things. As long as they're synchronous with the vent, they appear comfortable, that's not a problem in and of itself, and it's not necessarily a call for more sedation. What are your thoughts on that?
That's absolutely right. If the patient is setting their own rate, they've got their own metabolic demand or their own demands, it's totally fine for them. The big difference is, are they fighting the ventilator? Are you noticing, are they coughing and hacking? Are they gagging? Are they triggering peak pressure alarms? Are you seeing breath stacking? In those cases, then the sedation is what you need. And certainly if someone appears uncomfortable, if they're tachypnic and tachycardic and all those typical signs of discomfort, that needs to be addressed. But if they are comfortable appearing, like you said, and just overbreathing, that's something that we can manage. In those patients, we'll kind of delve into some of the ventilator stuff at a different one. But some of these patients that are overbreathing and they have a higher demand, it's worth considering pressure control. That meets their demands better than assist control does, or CMV Plus on these ventilators will. And that's something that we'll discuss at length in another video. But yeah, good question.
Excellent.
And one other thing I guess we should throw in here. It's a 7.0 ET tube. We see that quite often from outside facilities. It is to your patient's benefit to use the largest tube that you can put down there. Each drop in size of the ET tube, well, I can't remember what the formula is, but dropping it from an 8 to a 7.5 decreases the amount of airflow going through there significantly. Biofilm can build up on that tube rather quickly. That further limits your airflow. That will limit, the air moving in and out, causing increased pressures. It makes it more difficult for that person to exhale. Can prolong wean times, increase vent times. So the biggest tube that you can get down those people, the better, particularly if it is an obstructive process. So.
Super. Well, thank you, Jesse. Appreciate your time.
Thank you.
We have here nitric acid, glycerine, and a special mixture of my own. Together, it's horrible, dangerous stuff, blows you up. But mixed together in the right way, as only I know how, what do you think it makes?
I don't know, sir.
Of course you don't know. You don't know because only I know. If you knew and I didn't know, then you'd be teaching me instead of me teaching you. And for a student to teach his teacher, it's presumptuous and rude. Do I make myself clear?
Yes, sir.
Good.